Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers, and today the topic is syphilis. In 1999, we were getting close to eliminating the sexually transmitted infection, which can be devastating if not identified and treated early on. In recent years, however, syphilis rates rose in the U.S. and have climbed to all-time highs. Stephanie Desmond talks to Dr. Khalil Ghanem about how we got here and what can be done. Let's listen.
Khalil Ghanem, thanks so much for joining me.
Thank you so much for inviting me to join you.
So today the topic is syphilis. I understand that the syphilis rate is growing at an alarming pace in the United States. And I want you to talk about sort of what that looks like. And if you could also remind folks what syphilis is.
Sure. So I'll start with the second part of the question. What is syphilis? And syphilis is, for the most part, a sexually transmitted infection. And it affects both men and women. This infection is particularly problematic if it's not treated, because this infection can spread throughout the body within hours to days after exposure.
Wow.
And it can lead to serious complications, such as neurological complications, eye complications, inner ear complications. And in pregnant patients, it can lead to early termination of pregnancy, or if it doesn't lead to early termination of pregnancy, it can lead to infections in the infants when they're born, or a few years after they're born. If they're not treated, it can lead to complications in the children who are not treated for syphilis. So it can be a devastating infection, and it is usually transmitted sexually. And other mode of transmission is vertically. What that means is it's transmitted from the pregnant mother to the fetus during pregnancy. The good news is syphilis can be treated, and it can be easily treated with penicillin. But you have to find the patients who are infected and then give them penicillin. And penicillin stops the course of the infection. But if there has been damage done before you give the penicillin, sometimes that damage cannot be undone. So that's why it's so important to find people early on after they're infected, to treat them very quickly, to stop the infection. That way, the damage is not done. And they are essentially, the amount of damage is significantly limited. Now, keep in mind, one last thing is that syphilis is actually, reinfections in syphilis are common. So the minute somebody gets treated for their syphilis infection, they are at risk for getting reinfected. There is no protection from the immune system. So people can get syphilis a dozen times if they're exposed to syphilis. Now, syphilis rates had reached their lowest recorded levels in 1999. And the reason why at that time we had the lowest levels, most likely, is because people were being very careful in light of the HIV epidemic. So the HIV epidemic was ongoing. We still were just starting to have effective treatment for HIV, and people were still very scared about exposures that could get them HIV, which are the same exposures that would get them syphilis. And so the rates of syphilis declined to their lowest level in 1999, which essentially drove the Centers for Disease Control, the CDC, to come up with a plan in 1999 to eliminate syphilis from the United States by 2010. The sad thing is that in 2000, the year after the plan to eliminate syphilis was introduced, the rates of syphilis started going up in the United States and elsewhere around the world. And for the last 22 years, because that's how much data we have 22 years, the rates have not stopped going up. And it's shocking because we have reasonable diagnostics for syphilis. We have pretty good diagnostic tests for syphilis. It only affects humans, right? There are no animal reservoirs like other infections. And penicillin is still the drug of choice, and there's no drug resistance. So you would think it would be easy to eliminate this infection, and yet the rates have been going up. Initially, the rates went up among men, particularly men who have sex with men. And that was the case for the first about 8 years. And then we started seeing rates going up among women and among men who have sex with women. And that over the last 10 years, the rates in women have gone up 800%. And as a consequence of the rates going up in women, the numbers of cases of congenital syphilis have gone up about 800%. And congenital syphilis is really, every case of congenital syphilis is a black eye for public health in general, because congenital syphilis can be completely prevented if pregnant patients are quickly diagnosed with syphilis and treated for syphilis. You can completely prevent congenital syphilis. So the fact that a country like the United States that spends so much money on healthcare is seeing such increasing numbers of congenital syphilis is absolutely horrifying and shocking.
So I imagine that many of the people who have syphilis don't know they have it. How do we get more people tested? Are there symptoms?
So there are symptoms in some patients. Now, remember, a lot of sexually transmitted infections don't cause symptoms. And with syphilis, you do have symptoms, particularly if this is the first time you get infected. If this is somebody who got reinfected again, the likelihood of having symptoms when you're reinfected goes down significantly. So reinfections tend to cause fewer symptoms. But first infections can cause symptoms. The first symptom that you have usually happens about 4 to 8 weeks after the exposure. And you usually get an ulcer at the site of exposure. So if the site of the exposure is the genital tract, you might get an ulcer in the genital tract. If it's the anus, you'll get it in the anus. If it's the mouth, you'll get it in the mouth. And these ulcers, the problem with these ulcers is usually they are painless. So unless they are visible, people don't pay attention to them. Often, particularly in women, because the ulcers tend to be either in the vaginal area or the anal area, the women are less likely to be diagnosed with primary syphilis. That's the first stage of syphilis, as compared to men, where these ulcers tend to be more visible more frequently. And then the ulcers, even if you don't diagnose somebody and treat them, the ulcers, the immune system will kick in and get rid of the ulcers completely. And then you go through a period where you have no signs or symptoms. And then the second stage of syphilis comes, and that's the stage where the organism is replicating very rapidly throughout the body. And the second stage can present with manifestations in any organ system of the body. The most common manifestations are a skin rash. Actually, there are 2 different skin rashes. And sometimes that skin rash can involve the palms and soles, but it usually affects the trunk and the extremities. And the rash can look like anything, absolutely anything. And that's why whenever you send somebody to a dermatologist for a skin rash, they always test for syphilis, because the rash can look like anything from syphilis. The other things that you can get are fevers, chills, lymph glands can become enlarged. Some patients can develop hepatitis. Some patients can develop eye findings. Some patients can develop neurological findings. Some patients can develop gut findings. So any organ system can be involved. And usually patients with secondary syphilis will have some manifestation, most often skin manifestations, for a couple of weeks. And then even if you don't treat them, the immune system kicks in and it makes the infection go away. And it doesn't really clear the infection, it just suppresses it. And then a patient it goes into a phase where they have no clinical signs or symptoms. And if you don't treat those patients and you follow them, about 60 to 70% will never have a problem with syphilis again. They will live with the infection for the rest of their lives without any other problems. Another 30 to 40% will have late complications of syphilis, and those can involve the heart, it can involve the skin, any organ system because of inflammation, and then the very feared complications of neurosyphilis, which involves the brain and spinal cord, ocular syphilis, which involves the eye and the eye structures, and otic syphilis, which involves the inner ear, and it can lead to ringing in the ears, deafness, vertigo, dizziness, all of those things. So that's sort of the natural history of syphilis. But remember, the minute you treat somebody, you are stopping the disease, but whatever damage was done is done.
How can we prevent this? I mean, it sounds like a real problem.
It's a real problem, and the rates are at an all-time high. I mean, the rates that we're seeing now are similar to the rates that we saw in the 1950s. We stop it essentially by doing what we normally do to prevent communicable diseases. So what is the standard approach? The standard approach is, one, you have to find the people that are infected, right? So to find them, you go out and you screen people. So you test people who don't have symptoms to make sure that they're not infected. And then, of course, you test patients who have symptoms. That way you find out whether they have syphilis or not. And then once you identify the people that have syphilis through testing, you go ahead and you treat them quickly. That's the second tenet. Find the people, treat them. And then the third tenet is find their partners. Because if you don't find the partners and you treat the partners, they're going to reinfect the patients. And so it's really important to go out and find the partners and treat the partners, and then continue to screen those patients that were treated to make sure they didn't get reinfected. And then, of course, then there's education. You want to educate so that both clinicians are aware of the problem and so that patients are aware of the problem as well. So that if a clinician doesn't volunteer to screen a patient for syphilis, the patient can go up to the clinician and say, hey, I'd like to be screened for syphilis.
It doesn't feel like it's a routine screening, however.
No, the problem is that, so it's easy to screen, right? It's easy because all it takes is essentially a blood test. The blood test will tell you if the patient has syphilis or not. But the problem, like every other STI, like every other sexually transmitted infection, and everything that we deal with in sexual health, right? There's a lot of stigma. And the stigma is not just with patients, right? Patients feel like if they're going to talk about sex and sexual health and risks, they're going to be stigmatized. And so that's one part of the equation. The other part of the equation, which we don't often talk about, is the fact that clinicians also, they also have stigma, right? They also attach these infections with stigma. I can't tell you the number of times I've had clinicians tell me, well, I don't test for syphilis because my patients don't get syphilis, right? And so it's shocking to me that in this day and age, we still have sort of the specter of stigma still causing such problems, both from the patient standpoint and from the clinician standpoint. And in fact, I think often clinician stigma detracts even more from screening than the stigma that patients feel. So it's a really difficult situation. The other big problem is access to care, right? There are many patients who don't have access to sexual health care. Over the last 5 years, there have been so many sexual health clinics in the country that have shut their doors because of funding. And so often young people may not have insurance, and these sexual health clinics were their only access to sexual health care and STI testing. And so by shutting down so many of these clinics, a lot of people now don't have access to care. And often it tends to be the younger patients that are dealing with these sexually transmitted infections. And because they're not seeking care for anything else, they otherwise tend to be healthy, it becomes difficult to find these patients. The other big problem that we face, remember, you also want to find the partners, right? In the olden days, you used to meet people at a bar, right? And then you went back home. And so usually what happened is if you got diagnosed with syphilis, somebody would come in, the DIS officers, we call them disease intervention specialists. These are the folks that the public health department sends out to find partners. And they go out, they ask the person, hey, who did you meet? And they'll say, I don't know the name, but I met them at this bar and this is what they look like. So the DIS officers could go to the bar, ask the bartender. The bartender would say, "Oh yeah, that's Jess." And so you would wait for Jess to come, and then you would treat Jess and be done with it. The problem now is that most people are meeting their partners on apps, on these apps, that dating apps, etc. And it becomes really challenging for DIS officers to go out and find partners because they didn't meet in a physical location per se, and the only thing they have to go by is the names that these individuals are using on these apps, which can be very difficult to trace. And so finding partners has become much more difficult. In the past, for each patient with syphilis that's diagnosed, they used to find 2 to 2.5 partners for that individual patient. Now, when you look at the number of partners that we're finding for each individual patient that's diagnosed with syphilis, it's less than 1. So it's become much more challenging to find partners. So we're not screening, we're not finding partners. As you know, those are the 2 main tenets to trying to control syphilis. It's no wonder that the rates of syphilis are increasing.
My one last question is about the rest of the world. Are we seeing this around the world, and is it increasing at the same rates?
So absolutely, wherever you look, for the most part, around the world, the rates of syphilis are increasing. That's absolutely true. For example, if we look at Canada, if we look at Europe, if we looked at Australia, where we have a lot of data, surveillance data, the rates are going up. There's only one country that I know of where the rates over the last 20 years have actually come down in some populations in that country, and that country is China. China started in the late 90s, early 2000s with a huge epidemic of syphilis, both in heterosexual populations as well as their MSM population. And what they did was they actually started spending a lot more money to control the infection. So they upped up screening, testing, treatment, etc. And all of that led to declines in the rates, the very high rates of syphilis that they had. The rates started declining, particularly in their heterosexual population. But the rates among MSM in China, based on the data that we have, suggest that they are increasing. So in most parts of the world, wherever you're looking and wherever we have data, the data suggests that the rates of syphilis are actually increasing, just like in the United States.
Where do we go from here?
Yeah, that's a great question. I think that, I think the main underlying driver for all of this is stigma and access to care. I think those 2 things really are driving the epidemic for all sexually transmitted infections. And we need to be able to address stigma. And the only way to address stigma is by approaching it not from a disease standpoint, but from a health standpoint. Right? We need to be able to talk about sexual health and to provide sexual health in an open way so that patients and providers feel very comfortable talking about these things. So sexual health, I think the approach, which is a sexual health-based approach, is the only answer that we have potentially to stigma. The big driver of what's really happening, those increases, can be traced back to the amount of funding. It's always about money, right? And now it's going to cost a lot of money to control this outbreak. Remember, we know how to control it, but it's hard. Screening is hard because people don't have access, so we need to put money into that. Screening is hard. Finding partners is hard because, it's not easy to do that. And so we need a lot more DIS officers, and they have to be given different tools to be able to find those partners. All of that takes money. And there needs to be money. And if you look at the amount of money that the federal government is spending on STI prevention over the last 15 years, that number has been stable, which essentially means that with inflation, in fact, the buying power of that money has come down 40%. So we have taken a 40% cut in money for STI prevention over the last 15 years as the rates of these STIs has gone up and up and up. So that tells you that while people sort of say they're concerned with these increasing rates. The reality is they're not really spending the money that needs to be spent to control this infection. So until we do, the rates are going to continue to increase.
Halael Ganem, thanks so much for joining me.
My pleasure. Thank you for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.